Welcome along. This is a really focused deep dive, specifically aimed at surgical trainees gearing up for board exams, like the FRCS plastic surgery.
That's right.
Today, we're getting into lip reconstruction, definitely a core topic. We'll hit the main causes, the anatomy you absolutely need to know, describing defects, goals of repair, and then the various techniques.
Exactly. Straight to the point, clinically relevant stuff.
Perfect. So kicking off, what are the main reasons we actually need to perform lip reconstruction, the etiologic factors?
Well, the big two are trauma, obviously, and malignancy.
Right.
And when we talk cancer, squamous cell carcinoma, that's the most common one overall you'll see.
Okay.
But interestingly, on the upper lip, you're actually more likely to encounter basal cell carcinoma.
Ah, that's a good distinction to keep in mind for exams. SCC, overall PCC, more common up top.
Precisely.
Yeah.
Worth remembering.
So to reconstruct well, you've got to know the anatomy inside out. Let's break down the layers and those key external landmarks.
Okay, so layers first. You've got the skin, naturally.
Yeah.
Then subcutaneous fat. Then the muscle layer. Really important here, orbicularis, oris, and mentalis are the key players.
Orbicularis being the sphincter.
Exactly. And then deep to that, the mucosa.
Got it. Skin, fat, muscle, mucosa. And externally, what are those landmarks we need to identify?
Externally, you need to know the commissure, obviously the corner of the mouth, Cupid's bow on the upper lip, the philtral columns, those vertical ridges running down to the bow, formed actually by the orbicularis fibers decossating, meeting there.
Right.
Then the central tubercle of the upper lip vermilion, the white roll, which is that distinct pale border just above the red part of the lip, again formed by orbicularis.
A visible edge of the muscle, yeah.
That's it. And finally, the red line, which is really the wet, dry vermilion border.
Okay, solid anatomical foundation there.
Yeah.
And the lip isn't just treated as one block, is it? We think in aesthetic units.
Absolutely crucial point. The upper lip had 3 units, 2 lateral ones, and 1 central medial unit, the philtral unit.
And the lower lip.
The lower lip is generally considered a single aesthetic unit.
And why is recognizing these units so important?
Because many of our reconstructive techniques, the incisions and flap designs, they aim to respect these unit boundaries or place scars within them. It helps achieve a much better aesthetic outcome, hiding scars where possible. And remember, boards assess both function and form.
Makes sense. So thinking about function, let's talk muscles. The muscles of facial expression are critical here.
Oh, absolutely vital. They control lip movement, expression, and you need to be mindful of potential nerve damage during dissection.
Any specific anatomical point to highlight?
The modiolus is key. It's that dense, mobile point just lateral to the commissure where several facial muscles converge and insert.
Right, a hub of muscle activity.
Precisely. And going back to orbicularis, oris, meticulous reconstruction of this muscle is absolutely paramount.
Why specifically?
To restore and maintain oral sphincter competence, that ability to seal the lips properly. It's fundamental for eating, drinking, speech. Examiners definitely focus on functional outcomes related to this.
Got it. What about sensation? Which nerves supply the lips?
Sensory supply comes from branches of the trigeminal nerve, V. The upper lip gets its sensation from the inforbital nerve, which is V2,
Okay.
and the lower lip is innervated by the mental nerve, a branch of V3.
So V2 up top, V3 below. Good to know for potential deficits or nerve blocks.
Exactly, and for trying nerve-sparing approaches when feasible.
Now, blood supply. Essential for any flap reconstruction, what are the vessels?
The main players are the superior and inferior labial arteries. They branch off the facial artery.
And their location.
They typically run deep to the orbicularis oris muscle, quite close to the red line, the vermilion border. So you need to be aware of that depth when raising flaps.
Deep to muscle near the red line. Okay. And finally, for anatomy, lymphatics. Important for cancer staging.
Yes, the drainage patterns differ slightly. For the lower lip, the lateral parts drain mainly to the ipsilateral submandibular nodes.
Ipsilateral submandibular.
But the medial third, the central part, can drain to both the submental nodes and the submandibular nodes. And crucially, it can cross the midline.
Ah, potential for contralateral spread from the middle.
Exactly. For the upper lip, it's primarily ipsilateral submandibular nodes again, but occasionally you might get drainage to ipsilateral pericular nodes, infericular parotid nodes, or even submental nodes.
So understanding those pathways is key for planning neck dissection if needed.
Absolutely. Standard board exam territory there.
Okay, great anatomy overview. Now, let's say you're presented with a defect. How do you describe it properly for planning and, well, for discussing it in an exam?
You need several key parameters. First, the size. both the absolute length, say in centimeters, and crucially, the proportion, what percentage of the total lip length is missing. Like, is it 20%, 40%?
Okay. Absolute and relative size. What else?
Depth. Is it just skin and vermilion, partial thickness, or is it full thickness, involving skin, muscle, and mucosa?
Full thickness being the most challenging.
Generally, yes. And finally, and this is critical, is the commissure involved? Does the defect extend into the corner of the mouth?
Right. Size, depth, commissure involvement, that really dictates the approach.
It absolutely does.
So what are we actually trying to achieve with lip reconstruction? What are the main goals?
Number one is restoring oral competence. That means ensuring muscular integrity, mostly the orbicularis, and maintaining an adequate oral aperture, the mouth opening.
How much reduction causes problems?
Significant dysfunction usually starts when the opening is reduced to less than about 50% of what it was preoperatively. Also need to think about patients with dentures. They need enough opening to get them in and out.
Good point. Okay, competence first. What else?
Sensation is important, ideally. Restoring normal speech, or as close to normal as possible. And of course, cosmesis. Achieving acceptable aesthetic proportions and symmetry. Even a tiny mismatch, the vermilion border, we're talking just over a millimeter, can be really noticeable.
So function and aesthetics hand in hand. Oral competence, sensation, speech, cosmesis.
That's the target. Examiners will look for your appreciation of all these aspects.
Right. Let's dive into repair techniques now. Starting smaller scale, what if it's just a defect of the vermilion itself? Maybe some volume loss or a notch.
For isolated volume deficiency, you have a few options. A VY advancement flap can work well for a small notch or defect.
Just advancing local tissue.
Exactly. For slightly larger vermilion-only defects, a lip switch flap, using vermilion from the other lip, can be good. It replaces with like tissue.
Wet vermilion for wet, dry for dry.
Ideally, yes.
Yeah.
You generally want to avoid using wet vermilion to replace dry vermilion because it tends to stay moist and can look out of place or get dry and crusty externally.
Okay. Any other options for volume?
Fat grafting is another possibility, just to plump up the vermilion if volume is the main issue.
What if it's a more significant chunk of vermilion missing, say up to half? Subtotal loss.
For that sort of 50% loss, you might consider an axial myovermilion advancement flap. That's elevated deep to the labial artery.
Okay.
Or a myomucosal VY advancement flap. Or, as mentioned, a vermilion lip switch flap could work here too.
And if it's even larger, more than half the vermilion gone.
Then things get trickier. A tongue flap is an option, but it's usually a two-stage procedure.
Right, division later.
Yeah. Uses tissue from the ventral, the underside of the tongue. The downside is the appearance often isn't ideal. It doesn't look quite like natural vermilion.
Suboptimal aesthetically. And for total vermilion loss.
For total loss, you might use a buccal mucosal advancement, basically advancing the wet lining from inside the cheek forward.
How does that look?
The color match can actually be quite good, but the tissue is inherently wet mucosa, so it's prone to drying out when it's exposed as external vermilion.
Okay, trade-offs there. Now, the bigger challenge, full thickness defects. Skin, muscle, mucosa all gone. Is there a guiding principle based on defect size?
Yes, the classic rule of thirds is a really helpful framework. It's not rigid, but it helps categorize defect size and suggest potential options.
Okay, let's use that. So smallest defects, less than 1/3 of the lip missing. What's the approach?
For those, primary closure is often feasible, just closing the defect directly in layers.
Advantages.
It's single stage, which is great. You preserve the native innervation, so sensation is maintained. And you get direct muscle continuity, restoring the orbicularis function.
Sounds ideal. Disadvantages.
Well, it's really only suitable for fairly small defects, and particularly on the upper lip. Direct vertical closure can obliterate or distort important landmarks like Cupid's bow or the philtral columns. That can be quite noticeable.
So, aesthetic compromise possible on the upper lip. Any technical tips?
Precise layered closure is absolutely key. Skin, muscle, mucosa need to be aligned perfectly, especially that vermilion border. Sometimes you might add a small crescentic excision of skin near the ala, the nostril base, to help medialize the lateral lip elements and maybe camouflage the scar a bit.
Okay. Moving up in size, defects between 1/3 and 1/2 of the lip, but the commissure is still intact. What's the workhorse here? The Abbé flap.
The Abbé lip switch flap is definitely a primary consideration in this scenario.
Right. Remind us of the principle.
You're basically taking a full thickness flap from the opposite lip, based on its labial artery, and rotating it into the defect. The donor site on a healthy lip can usually be closed primarily.
What are the pros?
Big pro is it brings in innervated muscle, so you get good muscular continuity across the defect eventually. It reconstructs like with like.
Cons.
Major con. It's a two-stage procedure. The flap stays attached by its pedicle across the mouth for a couple of weeks. Needs patient compliance. And the flap itself will be insensate. No feeling.
Okay, 2 stages. Insensate flap. Technical pearls for the abbe.
Flap design is crucial. It should be roughly half the width of the defect you're filling. Make it full thickness. You need to plan the rotation point carefully to allow enough mouth opening during the interim stage and preserve a cuff of muscle around the pedicle, the labial artery,
Blood supply comes from.
the ipsilateral labial artery of the donor lip, the opposite lip.
Got it. And the second stage?
Usually done around 2-3 weeks later. You test the flap's viability by gently clamping the pedicle first. If it stays pink, you divide the pedicle. Often a small wedge resection or adjustment is needed then to get the best final lip contour.
Why might you prefer abbe over just sliding local tissue for an upper lip defect of this size?
Because the abbe does a much better job of preserving those key upper lip landmarks, Cupid's bow, philtrum. Sliding flaps often distort them more. That's a key point.
Okay, good rationale. Now, larger defects, maybe 1/2 to 2/3 gone, and this time the picture is involved. What technique comes to mind?
That brings the Estlander flap into play. It's similar in principle to the abbe, rotating a flap from the opposite lip, but specifically designed for defects involving the commissure.
How does it differ?
It rotates around the commissure itself, essentially reconstructing it. An advantage is that it can potentially be done as a single-stage procedure.
Potential single stage. Downsides.
Like the abbe, the flap is insensate. A bigger issue is that it inherently alters the commissure and can distort oral animation because it involves the modiolus region. A secondary commissuroplasty might be needed later to refine the corner.
Okay, animation issues. What about blood supply?
It's based on the contralateral labial artery of the opposite lip, similar to abbe, but the rotation can sometimes make the vascular supply a bit more tenuous. Needs careful handling.
So Estlander for commissure defects, but be aware of the functional and aesthetic compromises.
Exactly. Flap design is typically 1/3 to 1/2 the defect size, full thickness, with a muscle cuff.
Right. Let's shift back to central defects, again in that 1/3 to 2/3 size range. The Karapanzik flap is a well-known option here. Tell us about that.
The Karapanzik is a really elegant flap, essentially a rotational advancement flap using the remaining lip tissue from both sides.
What are its main advantages? Why choose it?
Big advantages. It's single stage. Crucially, it preserves the neurovascular bundles to the orbicularis oris muscle, so the reconstructed lip segment is sensate and functional. It maintains oral sphincter competence.
Wow, sensate and functional. That's huge.
It is. It also does a good job preserving the philtrum if it's an upper lip reconstruction and the modiolus isn't disrupted like in the Estlander.
Sounds almost perfect. Are there disadvantages?
The main one is microstomia, or a smaller mouth opening. This becomes more pronounced with larger defects, especially if you're reconstructing more than 2/3 of the lip. You can also get some tightness, particularly in the upper lip.
Microstomia risk. How is it technically performed?
It involves making circumoral incisions, basically around the mouth, but staying superficial initially. Then you perform careful intramuscular dissection to identify and preserve those labial arteries and sensory nerves. The flaps are then rotated inwards and advanced to close the central defect. It's a modification of an older flap, the Gillies fan flap, but specifically designed to keep those neurovascular structures intact.
So meticulous dissection is key. Blood supply relies on.
Bilateral labial arteries, essentially. You're carrying the blood supply with the rotating flaps.
Okay, Karapanzik. Single stage sensate functional sphincter, but potential microstomia.
That's a good summary.
What about really big defects? Greater than 2/3, especially central ones? What are the options then? Bernard-Burrow chyloplasty.
Yes, for those very large defects, the Bernard-Burrow technique, or its modifications, is often considered. It uses advancement flaps from the adjacent cheeks.
How does it work?
The classic technique involves excising triangles of skin, often called Burrow's triangles, typically in the nasolabial folds for lower lip defects, to allow medial advancement of the cheek tissue.
Advantages.
It's usually a single-stage procedure and uses local tissue, which is generally preferable if possible.
Disadvantages sound significant, though.
They can be. Often there's little to no functional muscle activity in the reconstructed segment, leading to oral sphincter incompetence. The flap is also insensate. And like Karapanzik for large defects, microstomia is a common issue.
So major functional compromise.
Potentially, yes. Buccal mucosa from inside the advanced cheek flap is often used to create a new vermilion border. The blood supply is just based on the random dermal plexus of the cheek flaps.
Is there a modification to improve function?
The Webster modification tries to address the muscle issue. It involves excising only skin and subcutaneous tissue in the Burroughs triangles, attempting to preserve the underlying muscle and maybe some nerve branches. The triangles are often placed more laterally or inferiorly too, but functional results can still be limited.
So, Bernard Burrow for large defects, single stage, but expect functional issues and microstomia.
That's the reality, often.
And finally, the extreme case, near total or total lip loss. What's the approach then? Free tissue transfer.
Yes, for total lip loss, you're almost always looking at free flap reconstruction. The radial forearm free flap is a common choice.
What are the components?
You bring in the skin paddle from the forearm for lip coverage. You can include the palmaris longus tendon, if present, to create a sling for lower lip support, helping prevent droop. The radial artery provides robust blood supply. And you can include the lateral antebrachial cutaneous nerve with the flap and potentially coapt it to a sensory nerve in the face, like the mental nerve stump, for some protective sensation.
Oh, potential for sensation.
Potential, yes.
Yeah.
But motor innervation isn't restored this way, so no active muscle function in the reconstructed lip itself.
Right. Other downsides.
Color match of forearm skin isn't always ideal for the face. Recreating fine details like the vermilion border and natural landmarks is also extremely challenging with a free flap. But it provides well-vascularized tissue, which is especially good if the local tissues are poor, perhaps due to radiation.
So, free flap for total loss
Yeah.
provides bulk and potential sensation, good for irradiated beds, but no motor function and aesthetic challenges.
That sums it up well.
Okay, we've covered a lot of techniques. Just briefly, post-operative care. What are the key things trainees should mention?
Post-op nutrition is important. Initially, advise proper-sized pieces or maybe a pureed or liquid diet, depending on the reconstruction and swelling.
Makes sense.
And hygiene. Good oral hygiene is crucial. If the patient has reasonable oral competence, gentle swishing and expectorating with an oral antiseptic solution. If not, careful, gentle cleaning inside the mouth is needed to prevent infection and help healing.
Right. So let's wrap up with some quick-fire key learning points for exam revision on lip reconstruction.
Okay. First, meticulous vermilion border alignment. Absolutely essential for cosmesis.
Non-negotiable.
Second, always aim to preserve or reconstruct key anatomic landmarks like Cupid's bow and philtral columns if possible.
Got it.
Third, be aware of microstomia risk, especially with excisions bigger than about half the lip.
Okay, 50% excision, microstomia risk.
Fourth, remember defects up to about 1/3 can often be closed primarily. Simple, single stage, but watch for upper lip
Up
distortion.
to 1/3 primary closure.
Fifth, Abbe flap.
Yeah.
Good for preserving the commissure, but it's 2 stages in insensate.
Abbe preserves commissure.
Sixth, Eslander flap.
Yeah.
Useful when the commissure is involved, but potential animation issues and tenuous blood supply.
Eslander for commissure involvement.
Seventh, Carapansic flap. The big advantage is preserving orbicularis, oris innervation, and sensation. But again, microstomia risk in large defects.
Carapansic preserves nerve.
Eighth, Bernard Burrow. Often compromises orbicularis function and sensation for large defects, but functional cost.
Bernard Burrow compromises nerve muscle.
And finally, total reconstruction usually means free flap, bringing vascularity and potential sensation, but no motor function and aesthetic limits.
Fantastic. That's a really solid overview. This has been a very focused, hopefully high-yield session on lip reconstruction geared towards your surgical board exams.
Hopefully very useful.
We definitely encourage you to consolidate this, maybe sketch out the flaps, think through the principles. Continuous learning is really the name of the game in surgery.
Absolutely. Keep studying.